Imagine sitting in a cold, sterile consultation room. The fluorescent lights are humming. The paper on the exam table crinkles every time you shift your weight. Across from you sits a highly trained professional. They're holding a chart. They look competent, confident, and they're telling you with absolute certainty that you need an operation. They show you the scans, they point at the problem, and they say, if we don't do this, things are going to get worse. It sounds so clear-cut, doesn't it? Like the path forward is obvious. You trust them. They went to school for a decade. They save lives every day. The paperwork is already printed, a signature line waiting at the bottom. It feels almost disrespectful to ask questions. That is one of the most dangerous moments of your entire life. Not because the doctor doesn't know what they're doing, but because in that room, you are the only person who is thinking about you. The surgeon is an expert in the procedure. You are the only expert in your own life. And when you walk out of that room, you are the one who has to live with the outcome, not them. Now let's talk about the hard truth. There is a sacred pact we make with ourselves as we get older. We promise to stay independent. We promise to remain sharp, to play with the grandkids, to travel, to live on our own terms. But for a lot of people, that freedom is quietly taken away, not by a disease, but by the very thing meant to cure it, the operation itself. Because the reality is, a 70-year-old body does not respond to a surgeon's knife the same way a 40-year-old one does. It's not about attitude, it's not about willpower, it's biology, it's physics. And if you don't understand the hidden script, you might just sign away something you never intended to lose. Let's start by understanding why your body at 60 or 70 is a completely different machine than the one you had at 40. Think of it like a car with 200,000 miles on it. You can tune it up, you can keep the engine running smooth, you can maintain it perfectly, but you can't make it brand new. The metal has fatigue, the rubber has worn, the joints have settled. Now, imagine taking that car and putting it through the exact same stress test you'd put a factory-fresh model through. What happens? You have a catastrophic failure. And yet, for decades, surgery treated older bodies as if they were just a little older, but functionally the same. We are finally starting to realize that age is just a number, but frailty is a diagnosis. It means your reserve is gone. When you go under general anesthesia, it's not just sleep. Your heart, which has been pumping for decades, has to work harder to maintain pressure while the anesthetics relax your blood vessels. Your lungs, which may have been exposed to a lifetime of environmental pollutants or years of wearing down, take longer to clear the sedatives. Your kidneys, those hard-working filters, slow down, meaning the medications hang around in your system longer than they should. And then there's the brain. This is the one that haunts me. The brain becomes disoriented. We call it post-operative cognitive dysfunction. You might know it as that awful brain fog that lingers for weeks or months. People walk in sharp as a tack, and they come out different, slower, forgetful, never quite the same. And it happens far more often than we admit. Now let's get specific. Let's talk about the big one first. Open heart surgery. Coronary artery bypass grafting. It is a miracle of modern medicine. I have seen people get up and dance again after this procedure. But the brochure doesn't show you what happens during that miracle. It's a blunt instrument. To do the surgery, they have to stop your heart completely. They hook you up to a machine that breathes for you and pumps your blood for you. For a fit 60-year-old, it's a hard recovery, but it's doable. But take a 78-year-old with a bit of kidney disease, maybe a touch of adult-onset diabetes, maybe some early-stage cognitive decline, and that bypass machine becomes a brutally efficient way to assault every single organ in your body all at once. The statistics are sobering. For frail, elderly patients, the risk of major complications, stroke, kidney failure, prolonged ventilator use, hovers around 30 to 40%. And in the most severe cases, up to 15% don't survive the first 30 days. So what do? You ask a question that might change the entire conversation. You ask if a less invasive alternative exists. There's a procedure called TAVI now, a catheter-based solution that doesn't require opening the chest or stopping the heart. It is not for everyone, but it exists because smart people realized the old way was killing patients who didn't have to die. That question, is there a less invasive way, could be the only thing standing between you and a recovery that breaks you. Moving on to the spine. Back pain in your 60s and 70s is almost a guarantee. It's a wear and tear thing. And when a surgeon looks at an MRI of a worn-out spine, they see a place to fix. They see hardware, fusions, rods, screws. And sometimes, yes, it's critical. If a nerve is being crushed and you're losing control of your bladder, or you're about to be paralyzed, you don't have time to hesitate. That's emergency room stuff. But the elective spinal fusion, the one for chronic pain, this is where the evidence gets really uncomfortable. There was a major study in the journal Spine that showed for patients over 65, complex spinal fusions had a complication rate exceeding 40%. Not just infections, but something called adjacent segment disease. The hardware locks a section of the spine in place. It holds it tight. But the vertebrae above and below, suddenly bearing all the load of a moving body, start breaking down faster. The pain you had is gone. But now a new pain, a worse one, just moves up a notch. And here's the killer. Most of the time, the surgery provides no better long-term pain relief than dedicated physical therapy and targeted injections. No better, with exponentially higher risk. One of the most brilliant spine surgeons I ever met told me something I still keep in my heart. He said, "Sometimes the best operation is the one you don't do." I think he was talking about the human cost, the calculus of how many good years of life are you giving up to fix a mechanical problem that might have been manageable without a knife. Then there is the one nobody wants to hear about, the big C, cancer. When you hear that word, the instinct is nuclear. Get it out, now, cut it out. I understand that. I would feel the same way. But we have to talk about what happens when the treatment is worse than the disease. We need to be realistic about major cancer resections. Take the Whipple procedure for pancreatic cancer. It's one of the most complex surgeries there is. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. 6 to 10 hours on the table. In a younger, robust patient, it can be a lifesaver. But in an 80-year-old with underlying heart disease and reduced kidney function, The surgery might be a technical success, the tumor is gone, and the patient still passes away within weeks from complications. Not from cancer, from the operation. They call that futile surgery. And it happens more than anyone wants to admit. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly patients who underwent a major resection experienced a failure to rescue. That means a complication happened, and their body simply didn't have the reserve to fight back. So what should you say in that moment? Ask your oncologist, if we don't operate, what does watchful waiting, radiation, or targeted therapy look like for someone my age and my health status? That question opens a door, and sometimes the answer behind that door is a life with more years of quality, not just more years of survival. What about the ones we choose? Elective joint replacement. Hip and knee replacements are truly among the most successful surgeries ever developed. A new hip is a miracle. I have seen people walk out of the hospital without a cane. It transforms their world. But here's the catch. The word elective means you have time. You don't have to do it today, yet so many people rush in. For a patient over 75 with just 3 or more other health conditions, say heart disease, diabetes, and chronic kidney disease, the risk of per-operative complications skyrockets. The biggest danger is blood clots. Deep vein thrombosis that travels to the lungs and becomes a pulmonary embolism. In an elderly patient with poor circulation, that risk is dramatically higher. But here is something I wish every surgeon would say. Is your body in the best condition it can be in right now? Too many people think the surgery is the solution to the pain, but the surgery is a trauma. You are inflicting a controlled injury on the body to fix a joint. The healthier you are going in, the better you come out. Some hospitals are now requiring prehabilitation, optimizing blood pressure, blood sugar, weight, and cardiovascular function before they will even schedule the surgery. That is the right approach. If your surgeon hasn't talked about prehabilitation, you should be asking why. And then there is the worst one, the one you don't see coming. Emergency abdominal surgery. You don't choose this, it chooses you. A ruptured appendix, a perforated bowel, internal bleeding. These situations don't wait for a calm conversation. But knowing the risks beforehand changes how you react. In patients over 75, emergency abdominal surgery has a mortality rate of 30 to 50% in the most severe cases. The body is suddenly under siege. The liver, the kidneys, the heart, the lungs, they all get hit at once. The inflammatory response spirals into something called systemic inflammatory response syndrome, or SIRS. It's a cascade of biological chaos. The best protection? Don't ignore symptoms. Don't ignore persistent pain, bloating, or changes in bowel habits. Catching a problem early means treating it before it becomes a catastrophe. So you've gotten the bad news, or maybe you're just terrified. How do you walk into that exam room and come out the other side with your dignity, your health, and your future intact? There is a formula, a script for the patient. It starts with one question. What happens if I don't have this surgery? Ask it directly. If the doctor says nothing urgent changes in the next 6 to 12 months, then you have time. That is the golden gift. You have time to think, time to optimize, time to get a second opinion. The second question, is there a less invasive alternative?
You'd be shocked how many options exist now that didn't a decade ago. Robotic surgery, endoscopic procedures, catheter-based interventions. Third, what does recovery look like for me? Not the average patient, me. They should be specific about your organs, your meds, your home situation.
And the fourth, the one that makes the room uncomfortable. What is your personal complication rate for this procedure in patients over 70? Surgeons track this. They know the numbers. A confident, honest surgeon will tell you without blinking. If they get defensive, you have just learned something incredibly valuable. Now, let's talk about preparation. The 2 weeks before your surgery are more important than the 2 hours you spend on the operating table. Think of your body like a castle about to withstand a siege. You wouldn't go into a siege with your walls half repaired and your supplies low. You shore it up. That means eating more protein. Your body needs the bricks to rebuild tissue. Most people over 60 are under-eating protein. It's a quiet disaster. And you must walk every day, even if it's just around the block. Strong legs and strong lungs equal a patient who gets up and moves after surgery. And getting up and moving is the #1 thing you can do to prevent blood clots and pneumonia. If you smoke, stopping even just 2 weeks before surgery measurably lowers your risk of wound and lung complications. 2 weeks, that's it. There is another conversation we don't have often enough, and it's with the anesthesiologist. Remember the brain fog I mentioned? There are real things you can do to lower the odds of it. Ask for a pre-operative anesthesia consultation. Bring a complete list of every medication and supplement you take. The fish oil, the herbal sleep aid, everything. Some of those things interact with anesthesia in ways that surprise people. Ask if a regional or spinal anesthetic, where they numb just the area instead of putting your whole brain to sleep, is an option. And here is a small thing that sounds too simple to matter. If you wear hearing aids or glasses, ask to have them with you right up until the moment you go under, and back on the moment you wake. The research is clear. Patients who can see and hear when they wake up get confused far less often. It's a tiny adjustment that has a massive effect. And finally, get the second opinion. I know it feels awkward. You worry you'll offend the surgeon. Let me put that to rest right now. A good surgeon expects it. A good surgeon welcomes it, because they'd want one for their own mother. And if 2 highly qualified surgeons looking at the same scans and the same body land on 2 different recommendations, that is not a problem. That is information. None of this is about fear. It's about walking in prepared instead of hopeful. The patient who shows up strong, informed, and organized is a fundamentally different surgical risk than the one who shows up frightened and underprepared. Even when the operation is identical, you have more control over which of those 2 people you are than anyone has ever told you. This isn't a story about paranoia. It's about power. The power to say, I'm not signing anything until I know exactly what I'm signing up for. It's about sitting in that chair across from the surgeon and realizing that they are your partner, not your commander. They have the technical skill. You have the right to choose. And choice, made with open eyes and full information, is the most powerful tool in all of medicine. Stay curious, stay informed, and never, ever be afraid to ask the question that could save your life.